Hey friends, welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place to get spoon-fed the latest and greatest of emergency medicine. This is the audio version of the past week's summaries, which this week were brought to you by our authors Shannon, Marcus, Aaron, Lacey, Vivian, Leigh, Michael Stoker, and Clay Smith. Okay, now the fourth article, I didn't say it up until now, but Happy New Year's, everybody. This post, the fourth article from this week, was the top 10 most read posts from the Journal Feed of 2025. I don't think I'm going to go through all 10. Let's do the top 5, and let's talk a little bit about those. These are just some of the articles that we talked about this year. The number one most read post from the Journal Feed was the new 2025 AHA hypertension guidelines. These were important things, and these were really well done. I really like these guidelines. They support a lot of the practice that I like to do, already do, and think is appropriate for my patients. There's no such thing as hypertensive urgency. You don't have to start any medications in the emergency department, although you can if you think it's necessary and the patient does not have good follow-up. You can start with amlodipine. Plus minus an ARB. This is a reasonable choice. And of course, we are targeting a hypertension target of less than 130/80. That is the best we can do usually. And then the number 2 article was the new Sudbury Vertigo risk score and its derivation. We also covered an kind of external validation study. Now, if you remember, you listen to the podcast, you remember me talking about this, not a big fan of the Sudbury Vertigo risk score, but it is technically something you could use, but I don't think it's an amazing tool. We also covered a sort of external validation, but the data set included the derivation cohort, so I would consider it external validation. Then the third most read article was How to Intubate in 2025. Really the best evidence we have out there. This was really just a step-by-step about all of the steps of intubation and a lot of the literature that goes behind them, why we do things, why you should do other things and not something else. This is a great article. And this is particularly important. They quote that 40% of patients undergoing endotracheal intubation have a major adverse event. And so we want to be trying to do this as well as possible. Then the fourth article was that RH, immunoglobulin administration after abortion or pregnancy of less than 12 weeks gestation. This is from the AHA guidelines talking about this, and that's if they're 12 weeks or less than 12 weeks actually, then you do not have to give immunoglobulin against RH factor. This is an important point, and this puts us up, it kind of lines us up with some of the more international guidelines that have been doing this for a little while. This is great. This is very convenient. A lot of, if not most, abortions happen before this time, so this is a very important thing to keep in mind. And it's going to be less folks for your patients, less work for you, so less than 12 weeks. Although they do say that you can consider it if you want. It's not going to do much harm, but really less than 12 weeks, the risk of alloimmunization is pretty well zero. But you have to be confident it's really less than 12 weeks, otherwise, reconsider. And then the fifth most read article of the Journal Feed was the standing algorithm. This was the diagnostic accuracy of the standing algorithm for isolated vertigo. This is a multi-center prospective study, and I've said it before, I like the standing algorithm. Not because the test characteristics are that good, although they're pretty decent. It's just a solid way to approach vertigo, I'd say. And if you're not doing most of these things, I'm not sure what exactly you are doing. Standing algorithm, have a look at it. I'd say it's pretty good. I would use this well before thinking about the Sudbury risk score. Okay, I said I do 5, but I'm just going to add on the 6 just for fun. And this was a big review article talking about how C-collars and backboards and spinal immobilization in general seems to be essentially useless. So that's just something to think about, just try to think about that for your practice. Okay, that's it. That was essentially the summary of what we posted for this Thursday. And that was the top 10 articles from the past year. I covered the top 6. If you want the last few, then you'll have to look at them on the blog or just follow the link in your show notes. And then we had the last article from this week, which was titled Manual Bag Valve Mask Ventilation During Out-of-Hospital Cardiopulmonary Resuscitation, a Prospective Observational Study out of the journal Resuscitation. Now, BVM is super, super important. It's a skill that is difficult to do, but it's very important that we do well. It essentially decides whether or not your patient is going to be ventilated or not. And, well, you and I can intubate patients if that's not going well. For basic life support people, this is really all they're going to get. And that's the first line that we have for our patients. And so we want to be providing the best BVM possible for all of our patients. Now, there's something that's always been difficult about this, and that's been measuring the quality of BVM. It's kind of hard to do. It's easy to measure the rate, but how much air are you actually getting in? That is the really difficult part about it. Now, what's neat about this study is that they're using this new fancy device, which you attach between the mask and the bag, and it measures how much air goes in and how much air comes out. And so with this, you can measure the quality of your BVM. And that's exactly what they did. This was a study on firefighters, which were in France, and these were the first responders to a whole bunch of out-of-hospital cardiac arrest patients, 106 to be exact. And these were people who were trained to do BLS. Now, the inventor of this device is also apparently from France, and I can see online that they do training seminars with firefighters, at least in the United States, but they report no conflicts of interest, although I don't think that in this circumstance you're really going to have that many conflicts of interest, so I'm not too worried about it overall. So here's what they found. The median inspiratory volumes were about 500-600, whereas the expired volumes were more like 200-300, and we're trying to actually aim for higher. We're aiming for around 400. So what's coming out is presumably what actually went in. The difference between those numbers is probably the amount of leakage. What was interesting about this study is that very consistently, the second breath had larger volumes. So it probably means that you do the first breath and readjust a little bit. That didn't go so well. Or maybe now you're adding just a little bit of pressure, you're expanding the lungs a little bit that have been flattened out a bit by those chest compressions. And now you're providing, so you've opened it up and now there's more room for air. It's hard to tell exactly which one of these it is, but I'm going to hope that it's probably because we're getting better as we do have a little bit of practice. And as you continue to do more BVM on these patients, you get better as well. So this to me sounds like you're getting used to this patient's anatomy, you're adjusting your hands and you're providing better BVM. Not surprisingly, chest rise was associated with better breaths. And so this is something you can look for and is still an important marker. And this whole thing made me think a little bit about, how we thought that smaller bags would be better for BVM in the OCA scenario, but that didn't turn out to be the case in that one study that they did. Maybe this is why. Maybe because of all this leakage that we're having, that a better bag is actually better. Better bag is actually better. If your whole bag is only 500 mLs, then you can't afford to lose very much in leakage. And here we're seeing almost half of the volume lost in leakage. So then you're never going to get very good volumes. And so maybe that's why we need that big bag. If you didn't leak though, then maybe it wouldn't be so useful. For the first breath, the leakage was about 200 cc's and 170 for the second breath. So we consistently see that people get better on that second breath. The other thing to think about is maybe I think you're getting better seal, but maybe you're breaking ribs and you have better lung compliance because you have better chest compliance. But I think it's because we're just adjusting seal and doing a better job. The question is, how well would these numbers apply to people with more experience instead of firefighters, actual medical personnel who probably do this more often? How would it apply there? We don't know yet. But now that we have these nice little devices that we can measure it, hopefully that's coming and we can get a better idea. And if you were actually doing this yourself in the wild, then you have a feedback mechanism besides chest rise to see how well you're bagging. And that's also an interesting subject. I really look forward to future evidence that uses more of these devices so we can get more information on how well we're doing BVMs. In a spoonful, we don't BVM very well. We know that, but now we have a neat device that confirms that in BLS we are, again, not BVMing very well. I'd like to see more of this data and just to see if active feedback actually improves performance. The fourth article was the top 10 most viewed posts from the journal feed from 2025. What was your favorite? Please leave it in the comments of the blog. And then the fifth article was that we know we suck at BVM, and now we know how much we suck. However, we do seem to get a little bit better over time, even breath to breath. Okay, if you are hearing this right now, then you are not a part of the members team, so you missed 3 articles from this past week. What did you miss? We talked about what drugs you really should be giving for pre-hospital intubations, and then the AHA's guidelines on NRP. Links to all the original articles can be found at journalfeed.org, or just follow the links in your show notes. Our goal here is for you to keep up the easy way through spoon feeding. Thank you.